Hello and good afternoon to everyone. Thank you for joining our live webinar today with Dr. Bill Gibson. I'd just like to do a couple housekeeping items and then I'm going to pass it on to my colleague who is going to speak to you a little bit about the first link and referrals. So just please note that everyone is muted and that you will only have access to communicate with either myself or the presenter through the chat window, which you will see at the bottom of the right-hand portion of your screen. Any questions that you have, please type into there and Dr. Bill will get to them as the presentation goes along. Any technological issues as well, please type in there and I will do my best to help you troubleshoot. This is being recorded and will be available for viewing probably sometime tomorrow afternoon or on Monday. So please reach out to your local Alzheimer's Society Client Services person and ask them for the link at that time. Thank you, and I will pass it over to my colleague, Lori Grant.
Okay, great. Thanks, Christine. So good afternoon, everyone, and welcome to the webinar today. For those of you who don't know me, I'm Lori Grant, and I work out of the Red Deer office in the Central Region, overseeing the programs and services in the Central Zone. I want to start by saying we are very excited to see how many people are signed up today. The last I heard, it was over 200 people who have signed up to this webinar today. We were pleasantly surprised to see those numbers. But as a result, I'm going to ask if all of the Alzheimer's Society staff that are presently signed in, if they could actually disconnect to make sure that all of our community partners are able to get on. And then at about 1:10, 1:15, they can sign on again. So if you're with the Alzheimer's Society, if you could sign off, that would be great. So I'm going to just take 5 minutes of your time this afternoon to talk about outreach. As I'm sure is true for all of you, we have not been able to do any outreach with our community partners in the last 2 to 3 months due to COVID. And so we think it's really important to share with you how you might be able to access our information, our programs and supports from your community. And I really want to talk to you about First Link and the referral process and how you might connect somebody with us if they should need our supports. As you know, it's really important for people who live with dementia and their care partners to get the support and education about dementia that they need. We all witness how well people can do in the community in living with dementia if they have good information and they have great supports. Generally speaking, if people are left to their own devices, they won't connect with the Alzheimer's Society until later on in the disease, if they will at all. We witness all the time, every day at our work, the people that have been referred earlier are better able to cope just because they have those resources at their disposal. It's important for us as professionals in the community, I think, to actually facilitate that connection. Because when somebody's at home caring for somebody with dementia, sometimes picking up that phone and making that connection is just too difficult. So the First Link is a direct referral program where professionals like yourselves in the community are able to make a direct referral to us. And I always say when I'm talking about First Link that the pillars of First Link really are, number one, the direct referral, number two, the intentional follow-up that we provide for clients once they have been admitted to that First Link program. And also the third one is reporting back to our partners in the community. So we are able to close that loop and know that these people are being followed. So once we receive that referral, we follow people throughout the duration of the dementia, making referrals to appropriate resources in the community and providing support as we see and as they identify. I think it's really important to remember that the needs change over time as the disease progresses. So this intentional follow-up allows us to stay in touch and be able to assess and hear what people are needing during the disease process. And so it allows us to make those referrals when needed. So the First Link referral form is at the top of your screen right now in that green bar. You can access it and download it right now if you want to for future reference. You can also access it through the main page of our website. So you can access that referral form on there, and you're also going to get a copy of it emailed out to you after this presentation. So if you have any questions about the First Link program and how you can connect your clients to us, please feel free to contact your regional office and ask them about it. We won't really answer a lot of questions. I'm just having a look here to see if there's questions. We won't really answer a lot of questions about it today unless you want to save them till after Dr. Gibson's presentation, because I don't want to take up his time. But feel free to reach out to us and ask any questions you have. I also want to let you know that there's going to be a survey sent out after the presentation today, and we're asking you to watch for it in your junk box as well as your main emails. It often ends up in the junk box. It's really important for us to know how you felt about this presentation today. As I said, this is going to be one of a series of presentations, and we'd love to hear exactly what sort of things you would like to hear about during these webinars. So please take the time to fill out that survey and send it back to us, and we'll be better informed for the future. So without further ado, I want to introduce Dr. Bill Gibson. Bill completed medical school at the University of Sheffield in the UK, and he did postgraduate and higher specialist training in internal medicine and geriatrics in South Yorkshire, UK. He completed his Ph.D. in medicine at the U of A and is currently the assistant professor in geriatric medicine there, or a assistant professor. His clinical practice covers geriatric medicine, dementia, cognitive impairment, and incontinence at the U of A hospital and at the Glenrose. He also runs an outreach clinic in Vegreville. So welcome, Dr. Gibson, and take it away.
Thank you very much, Laurie, for that kind introduction. Are my slides around somewhere? I've not got slides. There we go. Okay. So thank you very much for everyone for spending your afternoon listening to me witter on over the internet. I know we're all doing things very differently at the moment, and it's very unusual for me to be kind of talking to my screen in my study at home rather than actually kind of talking to people and getting some interaction. So I'm feeling very lost and rudderless at the moment, as I suspect we all are. If you have any questions at any time, just type them in the chat box and they will ping up on my screen, and I will try and break off to answer them as best we can as we go. If you want to save them to the end, that's fine as well. I don't know what our time limits are. I'm here all afternoon, so I've got nothing I need to be off for, so we can carry on talking until everyone gets bored and goes home. So as Laurie said, I'm Bill Gibson. I'm a geriatrician and a assistant professor of geriatrics at the University Hospital. My clinical work is largely around incontinence. I do the incontinence clinic at the Glenrose, and a lot of my outpatient work is around diagnosing and managing dementia, particularly in older people. But I am more than happy to see anyone with dementia or any sort of geriatric quote unquote problems, no matter what age they may be. So I'm going to sort of talk through some of the basics around dementia, what it is, how we manage it, when we need to think about getting a specialist opinion, when we can manage things in primary care. I'm going to talk a little bit about the clinical features and our diagnostic process, and then our management, particularly thinking about when do we use the drugs, what else do we need to do, how do we manage BPSD, what to think about nutrition, and some issues around end of life with people living with dementia. So dementia as a process or as a condition is not at all new. It was first described by the ancient Greeks, kind of 1st, 2nd century BC and before. But it was really Galen of Pergamon, who lived from 130 to 201 AD, who identified dementia in old age as a particular disorder. The term dementia comes from the Latin, of course, meaning without, and mens being related to the mind or cognition. It was very much ignored through the Dark Ages and until the late Middle Ages, mainly because people were busy worrying about the plague, which seems, kind of prescient at the moment, of course. And up until about the 18th century, the term dementia referred to any form of cognitive impairment, no matter if it was dementia in old age, or Alzheimer's as we now call it, or dementia syndromes, but including things like traumatic brain injury, including congenital cognitive impairment. And really, it was the French physicians Pinel and Esquirol, who lived at the turn of the 17th and 18th century, who described senile dementia. Lots of people can't hear anything. Is that problem at my end or someone else's end? I'll pause while we deal with some technical issues. My microphone is definitely on. Yep. Hannah can hear me, so that's good to know.
Yeah, sorry, Dr. Gibson, that was from earlier.
Okay.
Yeah.
No, I think there was another one at 11 minutes past from Stephanie, says not getting audio.
Okay, I will take care of those. Don't you worry.
Okay, fair enough.
Thank you.
So yeah, so I'll carry on talking. Of course, this is being recorded, so if people can't hear me, hopefully they can hear it on the playback later on. I do also speak quite quickly. I'm trying to go as slowly as possible. If I'm going too fast, please just flag me or wave or something, and I'll try and slow down. So dementia initially described any form of cognitive impairment, but over time we've come to use dementia in a much more defined and specific way, referring to the syndromes with which we're familiar. So this is a lady of whom you may have heard. This is Auguste Dieter, who was born in Kassel in Germany in May 1850. Somewhat unusually for the time, she was educated. She finished high school. She was able to read, and she was numerate. And she got married to a chap called Karl Dieter in 1873. They had a happy marriage. They had one daughter. But in her 40s, she began to develop symptoms of cognitive decline. She started to be utterly convinced that Karl was having an affair with someone. She had significant delusions, and she became more forgetful. She developed delusions around her husband and around her child, and lots of strange behaviour. She would lock herself in the room and be terrified of things and not be able to explain why she did it. She's quoted as saying, "Ich habe mich verloren," I have lost myself. And she was admitted to the Stadtische Anstalt für Innere Epileptische, or the Institution for the Insane and Epileptics in Frankfurt in 1901, where she stayed until her death at the age of 56 in 1906. So Auguste is now famous in the annals and the histories of medicine because she was looked after by this chap, who was, of course, Alois Alzheimer, who was born in Bavaria in 1864, qualified from the University of Würzburg Medical School in 1887, and his MD thesis, interestingly, was about the on the subject of the earwax glands. But he trained as a psychiatrist and neuropathologist, and he worked in the institute in Frankfurt from 1888 until 1903, and he was mentored there by Emil Kraepelin, who's a very eminent neurologist at the time. And he became Auguste Dieter's physician in 1901 when she was admitted, and he kept in contact with her physicians after he left, and when she died, he asked that her brain be sent to him so he could examine it. And this is what he found. So this is the histopathology of Auguste Dieter's brain, which he presented in 1906 at the Westfalen Südwestdeutsche Immerrat, which is the Southwest Germany psychiatry conference. Very few people turned up to his lecture, and no one asked any questions, and the chairman's remarks are recorded as saying, "So then, respected colleague Alzheimer, I thank you for your remarks. Clearly there is no desire for discussion." It has been suggested that the reason for this was that the seminar immediately following Alzheimer's was a lecture on compulsive masturbation, which was somewhat more attended and generated more interest. But this was the first presentation, the first discussion of Alzheimer's disease as a specific pathological diagnosis and as a specific syndrome in its own right. So he published the following year in the German Journal of Psychiatry in 1907, and he had these pictures which were drawn using the silver stain from her brain. And he says in the paper, in the centre of an otherwise normal cell, there stands out one or several fibrils due to their characteristic thickness and peculiar impregnability. Numerous small miliary foci are found in the superior layers. These are determined by the storage of a peculiar substance in the cerebral subject. All in all, we have to face a peculiar disease. And you can see on the second picture from the left there, these neurofibrillary tangles, as we now call them, within the body of the cell. And this is the underlying pathogenesis of Alzheimer's disease. But if we're thinking about Alzheimer's and dementia as a disease process and as a syndrome, we first have to ask ourselves, what's normal for getting older? Everyone's cognition changes throughout the course of their life. People, obviously, when you're born, you have some reflexes, but you have very little in the way of rational thought. And all of these things are skills that we have to learn. And then as we go through our teenage years, we usually develop some semblance of self-control and personality, and we continue to change and develop throughout the life cycle. So what happens as we get older? So in normal, quote unquote, aging, and of course what normal aging is a whole other subject. Intelligence as an overall concept is generally unaffected. People will maintain their normal level of intelligence throughout their life. However, it is normal within normal aging for your short-term memory to become worse. You are less able to lay down and formulate new memories. But your long-term memory, particularly your autobiographical memory, is unaffected, again, in normal aging. People's reaction times increase slightly, so people take longer to perform reflex actions, and that has implications on things like driving. And your processing speed decreases, so older people, healthy older people, will take longer to process incoming sensory data, use this data to make decisions, and your overall processing speed can decrease. And your vocabulary, interestingly, carries on increasing throughout life. So your ability to learn new words and expand your vocabulary will continue rising, will be maintained, and you carry on improving this throughout the normal lifespan. And your learning ability does persist. So it's perfectly possible to learn new skills and learn new things, even in very late life, in the absence of cognitive impairment. So this is normal aging. Intelligence unaffected, learning ability unaffected, short-term memory is the one that does change. Which then leads us on to this concept of mild cognitive impairment. So MCI is one of the diagnoses that I make very frequently in clinic. So mild cognitive impairment describes a situation where someone has monodomain cognitive impairment. So only one thing is not working, most typically short-term memory, what we call amnestic mild cognitive impairment. But there are no other cognitive changes, so they don't have significant impairment in other domains. Crucially, with MCI, there needs to be no functional impairment. So although people are a little forgetful, they're less able to form new memories, they are fully capable of living a normal life and managing perfectly well without any assistance. And the prevalence of MCI in the over 65s is between 15 and 20% if you look hard enough for it. And around 10% per year will convert to a dementia syndrome. The numbers that I will tend to quote in clinic when I'm diagnosing someone with MCI is over the course of about 10 years, about 1 in 3 people will go on to develop dementia to a significant degree, which of course, looked at the other way, means that 2 out of 3 people that I diagnose with MCI will not go on to have a significant dementia diagnosis or significant problems because of it. Now, people with MCI will often need to think about some tips and tricks and coping mechanisms for the fact that their memory is not as good as it used to be. And the easiest and most obvious one here is to not try and rely on your memory if you know your memory is not working so well. So that's things like writing notes, keeping a diary. I have had several patients who use voice memos on their phone or even carry a small dictaphone around. So if they need to remember something, they can make a very quick note rather than having to rely on a memory that they know is fallible. Dementia, on the other hand, is a group of neurocognitive disorders, so it's not one diagnosis, but they're all characterized by progressive cognitive impairment, which is multi-domain. So by definition, you have to have more than one domain of cognition affected. It needs to be getting worse. It needs to be not present since birth, so this needs to be a new problem, and it has to have associated functional impairment. And the final point I've not put on the slide here is it also has to last more than 6 months. So in order to make a diagnosis of dementia, you have to be able to demonstrate progressive cognitive impairment, which is multi-domain, which is new, which is associated with functional impairment, and has been lasting for more than 6 months. Now, this is obviously a fairly common presentation, things that we see a great deal in clinics and in specialist clinics and in primary care. We see it in inpatients. How do we diagnose this? The diagnosis of dementia is a clinical diagnosis. It can be made based purely on a well-taken history and the examination. And the Canadian guidelines for neuroimaging, so CT or MRI, which I'll talk about in a little while, would suggest that this is recommended if there is a suspected structural cause, or there is a reasonable chance that the neuroimaging will change your management. And that is the crucial thing, that often we will see people well into their 80s or 90s who have a CT scan or an MRI scan, and really we do not make any big decisions based on that, and it doesn't change our management in any way. So we then have to kind of ask ourselves, well, what was the use of doing that scan in the first place? How has this changed what's going on? So my approach to taking a history from someone with cognitive impairment is it's very important to get a history from both the person who is presenting with cognitive change or presenting with potential dementia, and from whoever lives with them or spends a lot of time with them, so their partner or their family or their friend or whoever it may be. I always start off by asking the patient to describe in their own words what's been going on, when did you first notice a problem, how have things been affecting you. I like to get them to go back to when they last think things were normal and tell me what was the first thing that you noticed. Was it getting forgetful? Was it losing objects? Was it not being able to solve a problem like using the telephone or the TV remote, or difficulty preparing meals? Whatever it may be, working through some of the domains of cognition, which we're going to talk about shortly, asking when and how these have changed over time. While I'm doing this, I really kind of try and encourage the partner, the care, or the family or friend, whoever is there with you, who's going to give you your collateral history, to try and not interrupt at that moment, because it's very important that people living with dementia are still the person for whom we are trying to diagnose and the person that we're there to look after. It's very easy for me to basically talk to their spouse or their partner or their family or the friend, whoever it is, and very much exclude the person living with dementia from the conversation. And even with people presenting with very severe dementia, where the story that they're telling me is clearly not in keeping with what I would describe as an objective reality, even then I do like to try and get their story first, mainly so that they can feel that we're still talking with them and rather than just about them in front of them. But while I'm doing that, my eye is often on the partner, looking for the non-verbal communication. With no end of times, the person living with dementia will tell me how fine things is, they're managing perfectly well, and they'll be their son or daughter or spouse sat next to them shaking their head or looking worried or looking surprised or giving me sort of clues. So picking those up is really important. Once I've done that, and taken this history around the cognitive deficits, what their timescale was, concrete examples is often very useful. People can find it difficult to explain what the difficulties are, but by perhaps talking through their normal day and saying, so when you wake up in the morning, how do you get out of bed? How do you wash and dress yourself? Do you have a shower by yourself, or do you have trouble working out how to turn the water on? Do you choose your own clothes? Does someone choose your clothes for you? And working through an ordinary day is a very easy and quick way of establishing what kind of deficits people have. You also need to think about the sort of higher level deficits, so things like finances, taxes, paying the bills, preparing meals, the things which are more complex, and assessing their impact on people's function. So how is it affecting them on a day-to-day basis? So there are 6 broad cognitive domains that we like to think about and like to consider. And I'm going to sort of go through those in a little bit more detail. So broadly, they are learning and memory, executive function, perceptual motor function, language, complex attention, and what's called social cognition. So learning and memory comprises things like free recall. So free recall is where I give someone a list of objects. In the MoCA, it's face, velvet, church, daisy, red, for example. And a few moments later, ask them to repeat those back to me without any sort of cues or clues or context. You just say, a few minutes ago, I gave you 5 words to remember. Do you remember what they were? In the MoCA and the MMSE, it's important that those words are unrelated. So don't give them a list of 5 flowers, for example, because it's easier to remember a group of things than it is to remember 5 disparate classifications. Cued recall is slightly different. That would be where you actually give someone a hint or a clue or a suggestion that helps them. So it's cued recall is easier than free recall. Recognition is recognizing objects or pictures. So in the MOCA, again, you have the drawings of the animals, so it's a hippopotamus and a camel. Semantic and autobiographical long-term memory, that is memories of both tasks and life events, and that is often maintained well into a dementia diagnosis. And then implicit learning is skills that we've learned from long ago. So, people, writing would be an example of that. Being able to, use an old-style telephone, that kind of thing. So things and skills that we've learned over a long period of time. All these fall under the example of learning and memory. So this is one domain of cognition. So when we're taking a history from someone presenting with cognitive impairment and possibly with a dementia diagnosis, is the first sort of things that will go in. Alzheimer's disease specifically, learning and memory are often affected early in the disease process. Executive function is the next big one. This is a thing that causes a lot more functional impairment and is often more early and affected earlier in vascular dementia particularly. So there's things around planning, volition, and performance of actions. So things like planning a task, so sequencing events, decision making, so weighing up the information to make choices. Working memory is slightly different from short-term memory. Short-term memory is what happened 5 minutes ago. Working memory is what I'm actually dealing with right now, and it's a slightly different area of the brain that's used to do that, and it's a different cognitive function. So this would be things like serial sevens. So if you're subtracting 7 from 100, you have to remember that you got to 100, then to 93, then to 86. You have to remember what the task is. You have to be able to go through that. So that's not short-term memory, that's working memory. Feedback response is responding to something that someone does to you. So we can test this in a frontal assessment battery, where you ask people to tap once when you tap once and tap twice when you tap twice. So that's responding and then feeding back to something. Inhibition is stopping yourself from doing things. Now, in frontotemporal dementia, particularly, inhibition and disinhibition can be a real problem when it comes to affecting behaviours and affecting particularly sexualized behaviours and things. But inhibition in this context also refers to don't do something when I do this. So the test on the FAB here is when I tap twice, don't tap, and when I tap once, do. So it's remembering and processing and using an inhibition to not do something even though there's a stimulus. And flexibility is the ability to change and move between one thought to the next. So perceptual motor function is to do with how we perceive the world and how we interact with the world. So that's to do with visual perception, visual constructional reasoning. So intersecting pentagons on the MOSE is a test for this. And this involves using objects, putting things away. So often we'll have people presenting with later stage dementia who, they unpack the shopping and they put the cans in the fridge and the frozen food in the cupboard and things. And then perceptual motor coordination is about hand-eye coordination, so being able to pick up objects and particularly do this at speed, so catching things. And this then feeds into a lot of people's falls risk when they're living with Alzheimer's. Language is a further domain of cognition, so lots and lots of different tests for this. The easiest way to test language is just have a conversation with someone, and often I would ask them to describe something familiar. So describe the front of your house, or where do you live? Tell me about your apartment and where you live. So people with language disturbance would have difficulty with nominative aphasia, so naming objects or naming things and people, word finding, choosing the words that you want to use, fluency, so the ability to formulate a sentence at speed and be able to have an ordinary conversation. Grammar and syntax, of course, is the ability to follow the normal sort of rules and regulations of grammar, and receptive language, being able to understand and process language as it comes in. These are often affected in dementias, usually later on in Alzheimer's disease. In Pick's disease, you often get language disturbance earlier. One thing to look out for here is people who had a stroke and developed a language disturbance can present as having cognitive impairment, when in fact their cognition is perfectly fine, but their language processing is off. I had a chap a while ago who'd had a stroke that had gone undiagnosed for various reasons, who had very, very severe expressive dysphasia, so couldn't get his words out, but his receptive function was unaffected. He could follow 5-step commands very easily, but had been written off as having severe cognitive impairment purely because he wasn't able to understand the instructions when people were trying to administer a mocha. So he was scoring 3 or 4 on his Montreal Cognitive Assessment, not because his cognition was off, but because the instructions made no sense to him whatsoever. So it takes an open mind and quite a lot of time sometimes to work out that someone is not understanding the speech but can understand the situation, and then that becomes a very difficult thing to manage sometimes in terms of how we process that. In general, specifically thinking about Alzheimer's disease, language is affected later on. So if people are presenting with cognitive decline and a language disturbance, often that will be something that make me think, is this frontotemporal dementia? Is this actually Pick's disease? And then complex attention. Complex attention is around how we pay attention or how we interact with the world. So can we maintain attention, so sustained attention? People with cognitive impairment are very often very distractible, so they will flip from idea to idea. Divided attention is the concept of doing 2 things at once. So the classic example here is trying to drive and talk on your cell phone at the same time, which is much more difficult. In general, if you try and do 2 things at once, you do both of them less well. There was a classic paper by someone called Lundig Olsen, who was, I think, Swedish geriatrician who ran a nursing home. And they noticed that there were 2 groups of residents. There were the group who, if you engaged them in conversation while they were walking, were able to carry on walking along the corridor and talk to you. And there were those who stopped walking if you engaged them in conversation. So they're walking on the corridor, you talk to them, they would stop. And this had an incredibly strong predictive value for falls in the following 6 months, in that those who were unable to carry on walking whilst holding a conversation, the people who stopped walking while talking, were something like 8 times more likely to fall over in the following 6 months. So it's a diverted attention. If you're unable to cope with competing cognitive demands, is actually very disabling, because a lot of what we do requires doing more than one thing at once. And walking is one of those things that does require attention. Selective attention is the ability to concentrate on what you need to be able to concentrate on, rather than being distracted by everything. This is something that develops relatively late in life. Those people, if you've had sort of toddlers, you'll know that they're very, very distractible at 4 or 5, and it's not until you're sort of 10 or 11 years old that you start to develop decent selective attention to be able to concentrate on one thing at once and concentrate on the thing that you want to concentrate on. Processing speed is a function of complex attention. So if you have impaired complex attention skills, then your processing speed will drop. And this has a real impact on driving ability, because driving is a quintessential example of something that requires processing speed, selective attention, and dual tasking or diverted attention all at the same time. And although we all drive without really thinking about it, actually there's a lot of going on neurocognitively. It's very, if your complex attention is off, your driving is often impaired. And then finally, there's this concept of social cognition, and this is the thing that really leads to problems in people with either advanced dementia and quite early on in frontotemporal dementia. So these are things like recognition of emotions, both in one's own emotions and in other people's emotions, and being able to respond to those. And our theories of mind and self. So your self-identity relies on your ability to recognize that you are an individual within a social construct, and having insight into your difficulties, challenges, and behaviors is affected with your social cognition is affected. So we have 6 domains of cognition here that are then split down into lots of smaller parts. Any and all of them can be affected by dementia. The pattern of how they are affected when in each disease process is what we can then use to give us clues or give us information about what the underlying cause of their dementia is. In Alzheimer's disease specifically, we are looking at amnesia first. So short-term memory is the first thing to be affected in Alzheimer's disease. In frontotemporal dementia, often it's around language and behaviours. Posterior cortical atrophy affects your visual functioning first. So there are lots and lots of subtypes of dementia, and patients coming to clinic always have the question, is it dementia or is it Alzheimer's disease, doc? And then I have to kind of explain to them that at length how dementia is a group of conditions, of which Alzheimer's is one. One example I use is to say that, you know, I have 2 pets. I have a dog and a cat. So my cat is a pet, but not all of my pets are cats. So the most common form of Alzheimer's in the West is most common form of dementia is Alzheimer's disease, followed by vascular dementia. Vascular dementia, of course, being the process whereby you have a series of very small embolic strokes, each one too small to notice on their own, but over time they build up and start to cause cognitive decline. Mixed dementia, usually Alzheimer's and vascular. Lewy body dementia presents very commonly with visual hallucinations, often quite distressing visual hallucinations, slowing and stiffness and shuffling, so features of Parkinsonism, often with a tremor, and then cognitive decline. Posterior cortical atrophy affects the posterior cortex, obviously, as you would expect from the name, usually presents with visual disturbance and visual field loss early, and then progresses to memory impairment later. Pick's disease is a specific subtype of dementia caused by something called Pick's bodies within the brain, and this classically presents with language disturbance first, so people present with either receptive or expressive aphasia before they start to develop cognitive impairment. Can overlap significantly clinically with vascular dementia, and it's sometimes quite difficult to tell the two apart. And then finally, I put CADASIL on the list here. CADASIL is a genetic condition called cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. It's it's a miscoding of a thing called the Notch3 gene, which encodes one of the endothelial proteins within the vasculature. So people get lots and lots of subcortical infarcts early on, typically present in their 40s and early 50s with a frontal type vascular dementia. They have a classic appearance on MRI. Once seen, not really forgotten. It's quite a classic, very, very severe central ischemic change. And the clue here, of course, is that it's autosomal dominant. So one of your parents will almost certainly have had the disease. It's not that common in North America. I used to work in a place called Rotherham in South Yorkshire, which had a cluster of families who were all related to each other through some grandparents, and they presented very early. So there's a little cluster there. I saw quite a few people with it, but it's pretty rare. But there are numerous genetic causes of dementias like CADASIL that we just need to bear in the back of our minds, particularly if we're thinking about younger people presenting with dementia syndromes. I mentioned Auguste Dieter right back at the beginning. Her brain was reanalyzed in 2005-ish, and one group thought they recognized a thing called a presenilin 1 mutation. So presenilin 1 and 2 are both genes which express various proteins within the brain, and they are autosomal dominant, and people who express those get Alzheimer's disease very early in life. These are very rare. The genetic causes of dementias, genetic Alzheimer's and others, are unusual. They are more common in the early presenters, so people who present before the age of 65, but even then the majority of them are not genetic. There are a thing called the ApoE allele. So there's 3 types, ApoE 2, 3, and 4. So if you have 2 copies of ApoE2, you have the normal background rate. And if you have 2 copies of ApoE4, which is the bad one, quote unquote, your risk is about 10% higher than background. So for the majority of people with dementia, their dementia doesn't particularly impact on their family's risk of developing dementia. But it is sometimes it's always worth taking a family history about parents and grandparents. Do they remember their grandparents getting confused or demented early in life? You know, if their grandmother made it to 95 and was a bit forgetful, I'm not particularly interested. If their grandmother died in her 50s with forgetfulness and dementia, that then makes me wonder about the potential for a genetic cause. Clearly, if you're concerned about someone having a strong family history of dementia, there are genetic tests available and genetic counselling is available through the appropriate services. In general, we don't recommend genetic testing for the vast majority of people presenting with Alzheimer's or other dementias. So I mentioned briefly mixed dementia. So technically, Mixed dementia describes any presentation with a mixed underlying pathology, but it's most commonly and usually taken to mean a combination of Alzheimer's dementia and vascular dementia. But technically, you can, of course, have Alzheimer's and Lewy body, or Lewy body and vascular, or whatever it may be. But the commonest term when we say mixed dementia is we're talking about Alzheimer's and vascular dementia. So I mentioned before that our diagnosis is based on is a clinical diagnosis. It's based on a history taken by a suitably qualified professional of progressive cognitive impairment in more than one domain, lasting more than 6 months, with associated functional impairment and not present since birth. And if you can demonstrate that based on a history and assessment, you don't actually need to do a great deal more, apart from make sure that you're not missing an underlying cause which you can do something about. I'm going to talk about that shortly. But you don't need fancy tests, you don't need functional PET scans, you don't even need complex neuropsychological testing. And the diagnosis of dementia is not based on an MMSE or a Montreal Cognitive Assessment score or any other testing score. The testing score allows us to quantify someone's cognitive impairment. It doesn't diagnose it. We diagnose it based on history and examination. One of the things that we do need to think about and do need to do is exclude a treatable underlying cause. So this is a list which I was kind of knocked together. It's not by any means exhaustive, but this is my kind of mental checklist as to what I'm going through when I'm taking a history for someone presenting with cognitive impairment. First and front and centre is alcohol. Alcohol-related dementia is extremely common. It's often hidden. People don't like to tell us how much they drink. Alcohol causes dementia in lots and lots of different ways. People with alcohol misuse problems will often smoke as well. They'll often have vascular risk factors. They'll be hypertensive. They're often overweight. They often will have diabetes. Alcohol is directly neurotoxic. That's the point. That's why we take it. But chronic alcohol use can directly damage brain cells, and you also get the nutritional deficiencies like Wernicke's encephalopathy, which can cause long-term cognitive issues. So Korsakoff syndrome is technically a form of dementia, of course, but would be considered separate because it's not particularly progressive. But alcohol-related dementia is extremely common. So asking someone about their alcohol history, how much they drink, how often, how long for, how long really for, is of course very important. Second thing we want to think about is structural lesions. Is this someone presenting with a brain tumour? Now this can be, of course, a primary tumour or more commonly metastatic. One of the ones that I always worry about is the referral that says, thank you for seeing this 75-year-old lady who was successfully treated for breast cancer 10 years ago, and now she's got cognitive impairment. Breast cancer is notorious for coming back after a long time with what are called leptomeningeal metastases, so mets around the brain rather than within, and can present with cognitive impairment. So anyone who's had a cancer in the past or suspicious for a cancer diagnosis will justify a scan from me. Poorly controlled obstructive sleep apnea, so your big guy with a big neck who snores a lot, his wife's moved to the other room. If you're being woken up continually overnight, you've got very poor sleep hygiene, that can cause progressive cognitive impairment. And then you give them a decent night's sleep through some CPAP, and their memory gets better. Uncontrolled diabetes and over-controlled diabetes, particularly in the frail elderly, are big ones that I need to think about. So people with poorly controlled diabetes, of course, have vascular risk factors. They're going to be having lots of strokes, lots of risk of vascular dementia. But even more concerning from my point of view is these guys who have over-controlled diabetes. So the sort of, the guy in his 80s, not much in the way of comorbidity, no vascular complications from his diabetes, who's running an HbA1c of 4. You can guarantee that this guy is having hypoglycemic episodes overnight, waking up with a bit of a headache and not feeling very well, a bit hungover in the morning, takes a bit of time to get going. These are guys who are going down to 1s and 2s in the middle of the night, no one's noticing because they're asleep. Over time, this causes more and more and more neuronal loss. So one thing that I will do is get rid of particularly the long-acting biogranide, so things like glimepiride and glybuteride, all these kind of long-acting hypoglycemic agents. Metformin, of course, is perfectly safe because it can't induce hypoglycemia. But older folk on insulin with progressive cognitive impairment, older folk on biogranide with progressive cognitive impairment, I keep a very close eye on their sugars, and I would very happily run them between sort of 10 and 15, rather than risk them going low and causing further cognitive impairment. Along with that comes AF. So people who have unanticoagulated atrial fibrillation will be throwing off showers of microemboli all the time. And these guys are at very high risk of presenting with cognitive decline due to vascular dementia. When we're talking to people about AF, we consent them for anticoagulation based on their risk of major stroke, which is perfectly reasonable because strokes from AF are big strokes. If you have a full-on TACS because of AF, you have a 1 in 3 chance of dying within a month, and you have a 90% chance of ending up in a nursing home if you do survive. So anticoagulating AF is really important. But even in the absence of a big stroke, people with AF will be throwing off tiny emboli. And if you scan their brains, you can see that there's an awful lot of areas of lacunes and infarcts as a result of their clotting. So I would aggressively look for and treat atrial fibrillation in people presenting with cognitive impairment. The last 3 are smaller print things. They don't tend to cause reversible causes of dementia or things that we can't, that we can arrest the development of the disease by changing. But various endocrine disturbances, classically, of course, hypothyroidism. So when I was in clinic a while ago and had a woman referred who was in her 70s with progressive cognitive impairment, is this dementia, thank you very much. And she came in and she was quite a big lady and she was missing some of her eyebrows and she talked like this. And her TSH was 160. And once we got that under control, her cognitive function got a great deal better, understandably. So thinking about hyper and hypothyroidism, making sure we've checked the TSH is, of course, very important. Mood disorders are one of the things that we think a great deal about. So severe depression causes psychomotor retardation, i.e. you are just too depressed to think. And that can present with dementia or dementia-like syndromes. And when you treat it, things can get better. The problem is that depression that severe is often actually very difficult to treat and becomes treatment resistant and often will require ECT or fairly big doses of fairly powerful drugs. So someone who's presenting who is severely depressed, whose depression started and then their cognitive impairment, I will often ask our colleagues in psychiatry or psychogeriatrics to get involved there. And then, of course, there's the functional set. So people who are presenting with cognitive impairment that really doesn't fit. So is either very fluctuant or very situational. We have people who will get very flustered and very anxious, and when they get flustered, their brain just shuts down. These guys are often, of course, very difficult to treat effectively. And of course, all of these things can coexist with normal age-related forgetfulness, with mild cognitive impairment, and with any of the other causes of dementia. It is far more common to diagnose Alzheimer's disease in someone with mild hypothyroidism than it is to diagnose someone with hypothyroidism who you can make better by treating their thyroid and their cognition gets better. However, they are important to look for. Treating them can at least slow the progression of any coexisting dementia. These are things that we will review and make sure that we are treating. The big one that I've not put on this list is iatrogenic, which is where we've caused it. And we get a lot of people coming through clinic with cognitive decline, and you look at their meds list and they've been put on 50-quetiapine and zopiclone and lorazepam and trazodone, and there aren't enough drugs to floor a rhinoceros, and we wonder why their cognition is not working as well as we might like it to. So one of the very first things I'll do is take a good look at the meds list and see is there anything here that I can get rid of. And even if the diagnosis is not drug-induced cognitive decline, if the diagnosis is Alzheimer's type dementia, if they're working with a suboptimal brain because they have dementia and dementia diagnosis and an Alzheimer's process, having the brakes on because of unsedating medications is going to make things worse anyway. So being able to deprescribe and get people off inappropriate medications is a really important intervention. What investigations do we need to do? These need to be guided by the history and any features of any underlying causes. At a bare minimum, I would like to see a complete blood count, an electrolyte panel, and a thyroid stimulating hormone. And that's actually all we need in a blood test. We don't need to check people's B12 levels unless they're anemic or macrocytic. And the reason for that is, of course, that the brain is very good at protecting itself. That's why DKA happens, isn't it? We're not producing we're not controlling our glucose, so we desperately try and make something that our brain can use, even though it kills us in the end. And it's exactly the same with B12. If you're B12 deficient, you will use your B12 to protect your neurons well before you allow it to affect your bone marrow, because bone marrow will recover much faster and is much less important from an evolutionary perspective. So if someone has a normal MCV and is not anemic, there is no way that their cognitive impairment can be caused by their B12 being low. It just doesn't make any physiological sense. There is also no evidence at all that treating what people describe as a low normal B12 does anything for people's cognitive function, or indeed anything else. The point of a normal range is that's the normal range. Someone's got a B12 within the normal range, they don't need B12 replacement. And the final investigation that we would do is an ECG, purely to look for, firstly, AF, which we can treat, and secondly, if they have any conduction defects, because that then feeds into our decision-making process around treatment. So neuroimaging, we have basically 3 types of neuroimaging available. CT is the easiest and the cheapest. MRI gives a slightly better resolution and detail. And functional PET imaging. So FPET is a way of looking at blood flow and neural activity, and is the gold standard for diagnosis of dementia syndromes, but doesn't diagnose dementia. It helps us diagnose the subtype of people's dementia. So the diagnosis of dementia syndrome is still made on our history and examination. We would think about doing scans if you have a suspected structural lesion, if you have significant vascular risk factors, particularly in someone that you don't want to hit hard with vascular secondary prevention. If someone has a full house of vascular risk factors, but is otherwise well and in their 60s, you're going to get their cholesterol, their blood pressure, their sugars all down as low as you can. If someone's in their 80s and a bit more frail, you're going to think, well, do I really want to be pushing their blood pressure down to 110? That will allow you to make a more informed risk-benefit choice. If they've not got any significant vascular change on their CT, it's unlikely that hammering their vascular risk factors is going to change what's going on. So the fundamental question before we do a scan, and in fact before we do any test, is how is this going to change our management? How is this going to make something different? What am I going to do differently with the result? What am I going to do if it's normal? What am I going to do if the test is abnormal? If the answer to those questions are the same, you don't need to do the test. It is worth noting that we currently have significant delays for access to neuroimaging. People who I request CTs on now are being booked for the middle of next year, and that is not going to get better anytime soon, unfortunately. So if I'm seeing someone who's 90 already, and they're going to get their scan when they're 92, it may well change my opinion of whether or not one is desperately needed, unfortunately. And the decisions around how many scans we can do and how long it takes is well above my pay grade. So I'd like to talk about the management of dementia. So we've talked about how we would go around diagnosing and what the kind of process there is in terms of the history. A question, sorry. In what situation will I supplement with B12? I would supplement with B12 in people who are anemic or who have a demonstrated low B12 level. So if you have macrocytosis or anemia and a low B12, I would replace the B12. I wouldn't replace B12 if the level was normal in someone with presenting with cognitive impairment. I hope that answered that. So the management, we can divide our management of dementia into what I would call non-pharmacological and pharmacological. And to put this in context, I would say 95% of the management of dementia and dementia syndromes falls into the non-pharmacological box, which then sort of raises the question, why are you seeing me? Because what I do is drugs. But that's okay. The non-pharmacological management is, firstly, of course, treating the underlying causes of someone's dementia. People will often ask me about memory exercises or brain training or games like that. There is no good evidence for anything specific. There is good evidence that people with mild cognitive impairment who maintain a active intellectual life, so do puzzles, read for pleasure, keep abreast of current affairs, tend to do better than people that don't. Every week or every 2 weeks, it seems, there is a new diet or supplement or herb or spice or something which people will come to clinic and say, hey, Dr. Gibson, what do you think about whatever it may be? It was coconut oil for quite a long time recently. That seems to have gone by the wayside. Turmeric has been very popular recently. Ginkgo biloba had its time a couple of years ago. CBD oil is all the rage, and absolutely no evidence whatsoever for any of them. All the evidence which has been done, which is of any decent quality, has been negative, showing no effect whatsoever. What I say to my patients is, look, it's very likely to harm you. It's very expensive. Do you really want to spend your money on, a tub of coconut oil or turmeric capsule or whatever it may be, given that the chances are it's not going to do anything? Unfortunately, the world is full of people who will happily sell anything to anyone, but such is life. The pharmacological treatment of dementia is disappointing, I think, to say the least. There are the group of drugs known as the cognitive enhancers. So this is donepezil, Aricept, galantamine, rivastigmine, and memantine. Memantine Avixit is not covered by Blue Cross, unfortunately. The other three are with special authorization. They are licensed and used in mid-stage disease, defined as an MMSE between 10 and 25. They've been shown to slow the progression of the disease on average. And this is something that's really difficult to get across to people in clinic when you're starting a medication, because you have no idea if it's going to work. You have no idea, and in fact, you cannot know what the effect of the medication on that individual is. You can tell them that these are the numbers. So this is from the Cochrane review, which came out a couple of years ago, looking at, this is donepezil 10 milligrams versus placebo, and this is the change from baseline at 26 weeks in the MMSE score. So you can see here that the line down the middle, the mean difference at 0 would suggest that the placebo and donepezil are exactly the same. So overall, all the trials showed some change, but the mean difference at 6 months, taking donepezil versus not, is a change of 1 in your MMSE. So people who took donepezil had a 1.05 less of a drop in their MMSE compared to people that were treated with placebo. Similar change in the ADS-COG, which is a 70-point cognitive testing scale, again showed a 0.67, so a very small difference. They all got worse. Those with donepezil got worse less than those who were untreated or treated with placebo. There was no difference in the neuropsychological patient inventory, the NPI, measure of behavioural symptoms, and there was no difference in overall quality of life in these large meta-analyses of all the trials. So by treating someone with a cognitive enhancer, and the data are the same for all of them, there's no great difference between them, you will notice basically you will get worse slightly less slowly than if you don't. Now, some people are very happy to take the medications and take the risk because of that. Some people feel that it's not really worth it, and it particularly depends on the side effects. So all the cognitive enhancers work by boosting the levels of choline of acetylcholine within the brain, and of course they boost the levels of acetylcholine everywhere else as well. And ACH is used as a signal in our bowels, in our salivary glands, in our eyes, in our bladders, and all over the place. So people taking donepezil and all the other cognitive enhancers will often present with diarrhea and GI upset, often urinary urgency. We see a lot of that in the continence clinic. They get headaches, they have sleep disturbance, which is why we tend to give them first thing in the morning, not last thing at night. Weight loss, they can induce anorexia and indigestion, and people can often lose weight with them. More seriously, it can induce heart block and bradycardias. So people can and do have had bradycardic syncope when starting on donepezil, which is why we tend to do an ECG first. They don't need routine ECG monitoring, but it is nice to have a baseline. If they develop symptoms, you can repeat. Other drugs which we use, I prepared a big long slide about benzodiazepines and all the evidence, but I scrapped it and said no. Just there is, in the absence of long-term addiction, which unfortunately a lot of my patients have because they've been on benzos since the 1970s, there is basically almost never a reason to prescribe benzodiazepines to people living with dementia. They make delirium worse, they make falls worse, they increase risk of mortality, they make you drowsy, they have hangover effects, they worsen your cognitive decline. They are completely ineffective for challenging behaviours. They often make them worse as well. People with BPSD, behavioural and psychological symptoms of dementia, which I'm going to talk about shortly, when they are acting out or expressing unmet needs through challenging behaviours, often it's only their residual frontal lobe function which is stopping them from going completely potty and causing even worse problems. You give them some benzos and turn off their frontal lobes, they often get paradoxical disinhibition and things get worse. How about antipsychotics? So this will be things like haloperidol, quetiapine, risperidone, olanzapine. In general, they are not recommended. There was a recent Cochrane review for them in both dementia and delirium. Overall, the risk will outweigh the benefits by orders of magnitude. They have modest efficacy at best in terms of controlling behaviours and improving sleep, and they come with significant side effects. Again, increased risk of falls, cognitive decline, paradoxical disinhibition. There was one small study which looked at discontinuation of antipsychotics, and they calculated that you need to treat 4 people for 1 year with antipsychotic in dementia to score a good clean kill with one of them. These are very, very risky drugs. They have their place. We use them occasionally. But in general, we need to be very, very careful. We need to start at very low doses, and we need to review them regularly, because if they are not working, or if the side effect profile is worse than the problem that we're trying to solve, we need to withdraw and stop them. We in hospital are probably one of the worst for doing this, because people will come into hospital with an underlying dementia diagnosis, have a superadded delirium, be started on haloperidol or quetiapine or something, whilst in hospital to try and control their behaviours. And then no one reviews it before they go home, so people are then being sent back out into the community on antipsychotics that they weren't on before. And that's one of the things that we need to be better at in the secondary care situation, to not put you guys out in primary care in that situation of having someone just pitching up on these fairly dangerous drugs without a very clear plan of why. Sleep disturbance is a real problem. So as people's living with dementia, as their disease pressure progresses, day-night reversal becomes very common in late-stage disease. So people tend to go to bed later and get up later, and they revert to sort of teenage boy sleep cycle. This can be really challenging to manage. Actually, the best way of dealing with it, if at all possible, is to run with it, is to allow people to stay up later and allow them to get up later, and move the entire household onto their sleep cycle if you can. Now, if everyone's retired and is happy with this, it's not too much of a problem. Clearly, if you are the care partner of a person living with dementia who still works or wants to maintain your own social life or whatever it may be, it becomes very, very difficult to deal with that. If you do need to try and get someone back on a more sort of socially acceptable sleep cycle, sleep hygiene and routine is really important. So having a regular bedtime, having a bedroom which is appropriately temperature, so not too hot, making sure the bed is very comfortable. Often we'll have people come to clinic who are not sleeping well, and it turns out they bought their mattress in 1960 when they got married and never replaced it. So make sure they've got a reasonably new bed and decent pillows, and the room is dark and quiet. They have a milky drink half an hour before bedtime. They don't have too much stimulation last thing in the evening. All these things can help maintain a normal sleep cycle. If you need to use medication, melatonin is by far and away the safest choice. Has some pretty good evidence for preventing delirium, has some pretty good evidence for use in dementia. If that doesn't work and you need to use something else, a sedating SSRI like trazodone is probably the best choice of a fairly poor lot. I would avoid the short-acting benzodiazepines, so things like lorazepam. Zopiclone is probably the safest of the sedative drugs or sedating antihistamines. But again, you need to be really careful that you're not making things worse, because there are a lot of risks of sedating someone living with dementia. If you think about it, to make someone go to sleep, you have to switch their brain off. To switch someone's brain off requires some fairly beefy drugs. So by using drugs like melatonin, which are much more physiological, you're going to be safer. Antidepressants, SSRIs particularly, are of moderate benefit in early and mid-stage disease, and in people who have moderate to severe depression and mild dementia, then treating their depression can actually make their dementia better, and sort of reduce the impact of their dementia, of their depression on their dementia. There is very little evidence of benefit in severe disease, and often you'll have someone who's appropriately prescribed citalopram or whatever it may be when they had moderate dementia and it was helping, but then things have progressed over the course of the next couple of years, and they're still taking their antidepressant when they are completely incapable of expressing or even feeling depression because their dementia is so severe. So this is often a very good option for a nice quick win with some deprescribing. And then feeding and hydration and nutrition is one of the things which becomes a real problem in very late stage disease. So feeding, of course, is a learned skill. It's actually the very first skill that we learn. We begin by practicing swallowing our own amniotic fluid, and then as soon as we're born, we're latched on and we start to learn to swallow and coordinate the muscles of swallowing. As dementia progresses and as dementia becomes severe, both the hunger and thirst centres within the brain can be affected. And that then prevents someone living with severe dementia from even experiencing hunger and thirst as a concept. And families often find it quite difficult to get their heads around that because they think, well, they're not eating and drinking, they must be very thirsty. But actually, they're not. The sensation of having a dry mouth can be unpleasant, but that's not the same as thirst. And it's quite easily managed by mouth care and providing oral, lollipop sticks or whatever it may be. In less severe disease, people can present with weight loss and problems with feeding, not because of the actual ability to eat, but the ability to prepare meals, to plan meals, to get the shopping in, to convert, and the concept of I would like to have something for my dinner to I have cooked a meal and eaten it. The ability to feed oneself can be affected by motor and perceptual skills, so being able to get food off a plate and into your mouth. And of course, the ability to swallow safely can be affected, and people can be at risk of aspiration. There is absolutely no evidence at all that enteral feeding, whether it be by NG or by peg tube, in end-stage dementia does anything at all to increase survival or improve quality of life. There is really good evidence to suggest that it doesn't. The mortality of a peg tube insertion in someone living with severe dementia is about 30% at 30 days. So that's a real kind of very, very risky procedure to put someone through for almost no benefit, in fact, for no benefit. What has got, so as a result of that, the evidence and the guidelines are that we do not offer NG or PEGs to people who have end-stage dementia. And the corollary there is, we don't offer heart-lung transplants either. There's lots of medical procedures that we wouldn't even discuss with certain patients because they are inappropriate. And one of these, all the evidence tells us, have difficulty with. So all the evidence is that NG and PEG is an inappropriate intervention. So it's not even something we need to offer or advise on unless families bring it up with us. If family says, well, why can't we feed them? Then I'll go through the evidence and say, look, it really doesn't help. It's very uncomfortable. It puts them at risk of this and this and this. It's not fair. What has got good evidence is hand feeding by caregivers. So someone sitting down with someone and feeding them. Feeding at risk is perfectly acceptable. So we say, look, his swallow's not good. If he eats this cake, it may well go onto his lungs and cause pneumonia. But that's okay, because if you are living with end-stage dementia and are no longer able to swallow safely, you are entering the very last stages of your life. And we should be really concentrating on people's quality of life and dignity and comfort. And that would include feeding them pleasant food and allowing them to have the sensation and the taste of food rather than not doing that. And this is where proper advanced planning and discussion comes in, because the thing that we really don't want to do is end up in that situation with someone with very severe dementia, and this happens all the time, where people end up in the last weeks of their life and no one at any time has said to them or their family, you are living with a terminal disease. You wouldn't have someone with metastatic cancer and not tell them where they were going, what was heading, what the trajectory was. But we do this with dementia a lot. We don't have this conversation and say, actually, this is unfortunately a disease which has a significant mortality attached. It's it's a fairly slow process. The median survival is over 10 years from diagnosis. But people with dementia often will die as a result of their dementia, and the reason that it happens is often because of inability to feed. So I'm a specialist. I work in a teaching hospital, and I'm the guy to whom you will refer. So the question, of course, is who do I want to see? Who do I want you to send to me to see in clinic? People that I would really like to see in clinic are people who have early onset cognitive impairment, so before the age of 65. People who are progressing very rapidly, So people who've gone from working to very severely affected over a short period, and people who are presenting unusually. So people who are where it doesn't quite fit, where it's not in keeping with a pattern that we recognise. Anyone who has challenging symptoms, particularly behavioural symptoms, and people that need complex discussions. So people where their families are very keen for them to have peg feeding, for example, but you know, it's not appropriate. You know, that's the kind of conversation that I can have, and I have the time and the experience to have. But fundamentally, the whole point of being a consultant is that people consult me, and I'm very happy to see anyone who's people out in primary care are not comfortable managing for whatever reason that would be. So that's my sort of last slide in terms of my prepared. I see it's gone horribly over time, sorry. There's a couple of questions that come through, so that would be so Nida says, for patients who refuse their blood pressure meds and Synthroid, what do you recommend they take to make them compliant? So I think the first thing to do there is take a really good look at someone's medication list. And for every single drug on there, you say, well, why am I giving this? And does it matter if they don't take it? So someone who has dementia that's severe enough to mean that they're not able to have a rational discussion about medication, about why they're taking it. I would question how worried we would need to be about their blood pressure. And I would relax my blood pressure targets a great deal. Synthroid, of course, levothyroxine, they do need to take, because if they become hypothyroid, they're going to be more symptomatic and run into problems. Remember, you can give thyroxine once a week if you so desire. It's got a very long half-life. So you can give someone's levothyroxine all in one go. Asking home care to go in with for medication assist can be very helpful. Making sure that people are on as few pills and as few occasions as possible. So if you can get everyone onto once daily medications and give all their pills at the same time, that can be really helpful. But for majority of people who are having difficulty and refusing to take medications, if their dementia is getting severe and the reason they're not taking medications is they're not able to have that rational conversation about why, that may well be a trigger to do some pretty aggressive deprescribing and get rid of a lot of things. You know, you can be much more relaxed about people's vascular safety prevention once you've hit sort of severe disease. And the next question is, how do we help clients that are sundowning and clients with depth perception? So I assume they're separate clients. So sundowning is the problem where people's behaviours and symptoms of unmet need and things get worse at night, particularly. First thing to think about is that BPSD is this label, behavioural psychological symptoms of dementia, which actually describes an unmet need on behalf of the person living with dementia. And you can think about it in your own sort of personal experience, that if you are, you know, for example, listening to some English guy which on about dementia for over an hour, but you've been drinking a lot of coffee in the morning because you're tired and it's busy and you really want to pee, you start to get a bit agitated and start to get a bit fidgety. Now, being people who are able to understand the signals from our own bodies, who are able to understand their own needs, and crucially, are able to process and communicate those needs to others, you would be able to just nip off and go to the bathroom and have a pee, or if we're in a conversation, you'd be able to say, excuse me, I just need to nip out, whatever it may be. If you're living with dementia, you can't express those needs in a constructive way. And often those needs, be it hunger or thirst, or need to move your bowels, or need to pee, or even something as simple as just being bored because you've been sitting down, you can't express those in any sort of logical and expressive and semantic way. And these unmet needs will then express themselves in other ways. So people in hospital is the classic. You know, you get someone living with dementia who's admitted to hospital for whatever reason, they're getting better, they're sitting down all day. We get them out of bed in the morning, usually very early because the nurses like to get their blood pressure checked at 4 o'clock for no apparent reason, and they're sitting in a chair, and whenever they try and stand up, they get told to sit down, sit down, sit down, sit down. And they get antsy and they want to move, but they can't say, actually, I'm just bored, I'm going to go for a quick walk around the block because I want to move, stretch my legs a little bit, I'm getting a bit achy. They can't express that feeling. So they express it by trying to stand up, or moving people, or hitting, or shouting, or whatever it may be. So the first thing to do with the sundowning type behaviours and escalation behaviours is to examine what the behaviour is and when it's happening and what might be underlying it. If you have a 6-month-old baby and it's screaming at 2 in the morning, you don't give it haloperidol. You go in, you check its diaper's dry, you check it needs feeding, you make sure it's not too hot, not too cold. You do sort of parenting stuff. And often when someone's living with dementia, you need to do the same process. Are they thirsty? Are they bored? Are they hungry? Do they need company? Do they just need physical contact, someone to hold their hand? Do they need a drink? Do they need a pee? Do they need to move their bowels? Whatever it may be, we find that need that they're trying to express and meet it, and often that will help settle things down. If none of that's working and you need to think about using some medication, the key thing is not to end up chasing your entire tail. What we normally do is wait until someone's really wound up and then give them lots of haloperidol. What we should do is give them a more sensible drug, trazodone, for example, or loxapine, or if you really must, quetiapine or risperidone, but chart those behaviours and say, okay, so at 8 o'clock at night, this is when this guy starts to get wound up and starts to have challenging behaviours. We need to address those 2 hours earlier. So you need to give them, if you're using medication, give it earlier on. So give it at 6, give it a couple of hours before the behaviours. So then you can use a lower dose to maintain people rather than trying to bring something back. The other thing for people living in institutions, or particularly people in hospital, is not to escalate the situation, which seems incredibly relevant at the moment, because it's exactly what the police do in the US all the time, which is there is a minor situation where nothing's really a problem, someone starts to get agitated, and rather than just take a step back and calm things down and talk to people normally, often our caregivers and our staff will pile on or start to agitate things and allow things and escalate the situation. So really being cognizant and being skilled at de-escalation and taking a step back. The phrase I use in clinic all the time with the care partners of people living with dementia is this the hill you want to die on? Is this a discussion you want to have? If your partner who's living with dementia wants to have, a drink or watch some TV at 2 o'clock in the morning, does it matter? Does it really bother you that much that you want to have to kind of wind people up and get in a big argument and try and get them directed back to bed? When actually, if we just let someone walk around the hospital unit or let them be awake until 2 o'clock, whatever it may be, if we allow the behaviour to express itself and allow the need to be expressed, that can be a much more constructive way of dealing with things. But yeah, if you need to use medication, use it in plenty of time. Give it a good 2 hours before you're anticipating the behaviour is getting worse. But that, of course, requires a bit of following up and kind of sort of keeping an eye on behaviours over a few days to look for a pattern. Problems with depth perception. So people with dementia will often get changes in their visual perception. There is a very famous OT called Teepa Snow who does a lot of YouTube stuff, and she very confidently says that people with dementia can only see this much. There's no evidence at all to support that view. I think Teepa says an awful lot, which is very good, and her person-centered care talk is excellent. But I think she's a little bit left field when it comes to her ideas of visual perception. But certainly people do get problems with depth perception. It's very individual about what that problem is and what can be done about it. But one kind of key thing is high contrast. So it's very difficult to see grey on grey. It's very difficult to see white on white and black on black. So if you've got a white work surface, have a black plate. If your dining table is dark, have light coloured crockery, because then you can see where it is more easily. There's a fascinating study from a nursing home, I think it was in Germany, where they changed all the toilet seats from white to black, because the floor was white, the toilet bowl was white, the seat was white, and people couldn't see it and kept on missing. And they improved the bladder and bowel continence in a care home by huge amounts, purely by changing the toilet seats over to high contrast. So good lighting, make sure people have got plenty of lights on, make sure things are high contrast. So it's things like tables and work surfaces and plates, that kind of thing. Make sure you've not got a white plate on a white table or a black plate on a black table. Make sure that they'll be able to see, because you're maximizing the quality of the sensory input, which then allows you to compensate for the fact that your processing mechanism is not up to stuff. Okay, 20 past, sorry, I've gone on. I do that a lot. just to remind you all, I said earlier on that sort of 95% of what I do is non-pharmacological management. And a huge amount of managing people living with dementia is actually managing their care partners and their families and giving them the skills and the tools to manage these difficult situations. And people find it very difficult often to, lie. It would be a term to people, but people living with dementia have a particular reality, and allowing them to live within that reality and allow them to express their needs within that without winding things up by challenging is really important. So the Alzheimer's Society do some absolutely fabulous work in terms of their education programs and their support programs for people living with dementia and their care partners. So the First Link referral form is linked up there. So that is, really just have a stack of those in the office ready to go for anyone that you're diagnosed with dementia. Send them to the Alzheimer's Society, and they are a fantastic resource for people to use. And if there are any further questions, I'm delighted to answer them. I'm not seeing anyone typing, but speak now or forever hold your peace, as they say. One thing people often ask is how people get to see me. So there are several geriatric and care of the elderly clinics throughout the city. They're all accessed through central access. So there's a referral form. Just send those in. A question from Nida again. You're asking lots of questions. Excellent. Is it okay they don't shower for months? Yes, actually. Again, this is one of those things where it's like, yes, in an ideal world, they would shower very regularly. There is a balance to be struck between how much you want to upset the situation by forcing someone to shower compared to how much harm they're going to do by not showering them. Clearly, if they are, have horrendous problems with odour, if they are getting sores or infected pressure sores or boils or whatever it may be, we need to be a bit more forceful in terms of saying, look, you really, you have to have a shower, and using a lot of sort of gentle persuasion and things to get people in the shower. But showering every day is a relatively recent invention. 100 years ago, you would have Queen Victoria famously, of course, saying, I have a bath once a year, whether I need it or not. We are not. We don't have to maintain that sort of strict level of kind of very, very frequent personal hygiene. It's a societal normative. It's a societal norm. It's not a physiological essential. Not physiologically essential. So ideally people shower more than every few months, but often people will not. And if people are not coming to harm because of that, then it's okay. It's you will do more harm by trying to force the issue than you will be able to by showering them. And it's about finding that balance between finding a balance between what the person living with dementia expresses and wants and what we feel that they should have. Do I follow clients in follow-up, support both their progression and to support their caregivers? Yes. The problem that we run into, of course, is that I have one clinic a week. I only do half a day of general geriatrics. So I have sort of 4 follow-up slots a week, so 200 a year. So I can't follow up the routine dementias forever. I tend to follow people for about a year, maybe 2 years, and then hand them back to primary care unless there are specific issues. I do tend to pass them over to the Alzheimer's Society for the ongoing sort of pastoral support and that kind of thing. People. It very much depends on the individual. But yes, the short answer is yes. I try to.
Thank you very much, Dr. Gibson. I'm not seeing any other come in.
Oh, there was a voice from the ether. Who was that?
Sorry. It's Christine from the Alzheimer's Society, the host. I'm not seeing questions come in for the day. So I'm going to hand it back to my colleague, Lori Grant, to just do some closing remarks. And thank you again, everybody, for attending today.
as our first presenter in this webinar series. It was a great presentation, very informative, and thanks for asking or answering all those questions. It's amazing how something like COVID-19 can force us to really think about new ways of doing things, and I think that this webinar series is going to be an excellent opportunity for us to connect with our partners in community and provide some additional education. So thank you very much. I also want to just remind everybody if they can remember to try to complete that survey for us, so we're better informed about what we should do for the next presentation or the next webinar. So watch for it. It'll be out in the next couple of days. And I also want you to know that this Dr. Gibson's presentation will be recorded and available to people tomorrow. There'll be a link that you can follow in order to watch it again. So if you want somebody to watch this particular presentation, I would get a hold of your regional office and get that link. If there's, I think that we're good. I don't think there's any other questions. And so, yeah, we look forward to connecting with you in the future and watch for future presentations. We don't have them fully secured at the moment, but there will be some more webinars coming up. So thank you, everybody. Bye.